Hey guys, welcome back. This is our second video for the class. Before I begin, I want to do some catching up real quick. Number one, I really want to apologize for the quality of the videos. I looked at my intro video and man, it was some scary stuff. So I sincerely apologize. Hopefully, as time goes on, I get more familiar with doing these videos. The quality will increase, so will the production. I might have some dangers in the background, my kids doing some robots or something like that. But hopefully it'll get better. Number two, on the second part of chapter one of the intro to the DSM, I tried to upload my video and it failed horribly. So what we're going to do is I'm going to use Dr. Lambert's video that's on there for that section of the intro to the DSM-5. Please make sure you look at the video and you review it. It has very valuable information. It's very helpful for the preparation of your quiz for chapter one. So please review that chapter, and I apologize for the inconvenience and technological difficulties. I'm pretty sure that probably won't be the last one we'll deal with, but hopefully they'll become few and far in between. So let's talk about the topic of at hand, which is why we diagnose. So I'm going to start off with a definition of mental illness. And by this definition, I'm going to kind of springboard into a discussion on why we diagnose, what's useful, some of the pros and cons, how it's helpful for the profession, how it progresses along the profession, but also some of the negative components that come along with it as well too. So if you look on in your text, the wonderful psychopathology text, page 6, you have the definition of mental illness by APA. I'm going to read it to you, so listen carefully, please. A mental disorder is a syndrome characterized by clinically significant disturbances in an individual's cognition, emotion regulation, or behavior that reflects a dysfunction of psychological, biological, or developmental processes underlying mental functioning. Mental disorders are usually associated with significant distress or disability in social, occupational, or other important activities. An expectable or culturally approved response to common stressors or losses such as death of a loved one is not a mental disorder. Socially deviant behavior, e.g., political, religious, or sexual conflicts that are primarily individuals and society that are not mental disorders unless the deviance or conflict results in a dysfunction in the individuals as described above. So, if you heard a phrase that kind of got repeated consistently through that definition, is talks about your social, professional, and occupational lives. So we're looking at the importance of how those things impact. So when we think about why we diagnose, individuals are typically coming to counselors or mental health professionals because there is something that's going on in their life that's causing them distress and it impacts their everyday functioning. People can't go to work because they sleep too much, maybe due to depression. Having a hard time maintaining relationships due to disturbances in their thought disorder. May challenging themselves with different thought disorders or psychosis, dealing with possible schizophrenia. So we've got to keep those things in mind of how it really impacts our everyday functions. So when we think about diagnoses, we want to get this label put in to see how we can better serve these individuals. We use diagnoses to put people in, I don't want to say categories or boxes, but however, they help us identify and label their concerns, which allows us to best treat them in a clinical setting. So you have a individual comes in to your office and they sit there for an intake interview and they discuss, give you symptoms of feeling stressed in social situations, don't like going outside, rather stay to themselves. Sorry about that. Social isolation, you begin to look down to the field of possible anxiety disorders and see what's going on. Not because you're trying to put a label on them, but what you're trying to do is to take all the symptoms that they are experiencing, get a quote unquote diagnosis and find an approach to handle it from there, to go in and to figure out what's the best course treatment for this individual. when we think about diagnosing, one of the most important parts is for our clients, is giving them a peace of mind in regards to, so that's what that is, that sense of relief. I know in my experience in working in the mental health field, especially in community mental health, having individuals come into a session and talk about their symptoms and what's going on, and then you can say, okay, and you take in the information, might bring them back a session later and do some assessments and some screenings, and then you can come to them and say, you know what, with the information I gathered today, I looked in the DSM, and it seems like you're dealing with, panic disorder. And, it's almost like a sense of relief for that individual, so they finally got a name to go with it. But also, what else can follow along with that is the fact that they realize they're not alone in this battle. They're not the only person dealing with these concerns. Or they feel like they're struggling on themselves. That I know I've had experiences where clients have come in and they've said, I think nobody else is going through what I'm going through right now. I feel like I'm the only person that's I'm crazy. I'm not normal, and that's not the case. And so when we think about some of the benefits of diagnosis, it's the education aspect. It can help educate our clients. It gives them an idea of what's going on and their presenting concerns. Also, amongst professionals, we can relay information. We use the DSM and other clinical tools to say, hey, we looked at this category and this is what's going on with this client based on their reporting concerns. And they're dealing with ADHD or they're dealing with possible bipolar disorder. That allows us to communicate so we can understand what's going on with an individual. Or let's say in a typical scenario, you have somebody that comes in and you begin doing treatment with them and you're working with them on some possible trauma. Well, during the course of treatment, they have to move because they got a job relocation. So, and they're interested in continuing their services. So with your diagnosis and your documentation, when they transfer to another clinician, the clinician can open their notes and see what's going on and be caught up because they understand, this individual is dealing with post-traumatic stress disorder. So they can get an understanding of what that consists of, how they present, what they would look like clinically in regards to that. Once again, when we think about why we diagnose, it helps us organize the symptoms for the individual. You look at the DSM and any diagnostic manual, whether it be the ICD-10 or PDR, any medical terminologies, you see where people have done tons and tons of research on individuals presenting with these concerns, and they've really honed it in together to give you this criteria. So this book, the DSM, and other materials are basically tons and tons of valuable research that we can use to help treat our clients. It can be so helpful in regards to that. It can help us also differentiate between disorders. So are they dealing with a possible stressor-related trauma, or is it something as a result of death? You'll find out the key phrases such as comorbidity in the DSM. You'll learn about that here in this classroom, how things that can co-occur at the same time. Working in the federal prison system, we have a residential drug program. We have two tracks of this drug program. We have the program that consists of individuals who are dealing primarily with substance abuse issues, but we also have those who are dealing with substance abuse and mental illness. So they are having a comorbidity. They are dual diagnosis of treatment plans. So you have those who have a mental health disorder, whether it be psychosis, schizophrenia, bipolar disorder, trauma, along with a substance abuse disorder. So it's very important that we get those things, but it can really help us differentiate in regards to what's the presenting concern for individuals. As you will find out, and this is kind of the parts I don't really like about diagnoses, but it's helpful as you're getting rare professionals. Some of you may want to go into private practice. So they understand the importance of insurance and how that plays a big piece in regards to what we diagnose. Sometimes you're not able to provide treatment based upon certain diagnoses, and it's the frustrating part of why we diagnose. Some insurance companies don't bill, don't pay, don't cover services if it's a certain diagnosis. Let me tell you a quick story. When I first began working at CompCare in Madison County, Richmond, I was a intern finishing up my master's in clinical psychology. My first client came in at my first intake, my first day on the site. I was excited, nervous, anxious, all that good stuff. So I do my intake, and it's a gentleman coming in and having some concern in his relationship with his partner. A lot of conflict, a lot of arguing, a lot of discord between the two. Excuse me. So I'm taking down the information, writing it down, and in my head I'm thinking, what are we going? What's going to be the diagnosis? What's my provisional diagnosis? My first round diagnosis, not my permanent, just an idea what that provisional typically consists of. So when I get done with the intake and I write up my notes, I have them. I give them a V code. Okay, I'm dating myself. V codes are no longer used, but they were back then, and it was a code in regards to it was a partner relationship problem, since the client was complaining about his relationship, and that was the main source of stress for him seeking services. So I go to our treatment plan meeting that day to discuss it, and sit there in the meeting, and I'm presenting the client and giving the symptoms, giving the diagnosis, and I feel pretty good. And then my clinical director goes, no, that's not the right diagnosis. And I lean my head to the side like, well, yeah, that is, that's what you're presenting with. Here's the criteria, boom, 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 boom. And she's like, no, Bill, because unfortunately, this individual has this insurance, and that diagnosis is not covered by this insurance. So he's dealing with an adjustment disorder, and that's what will get him to get covered to get services. And that about blew my mind. And I had a real hard time with that, with the importance of how much insurance impacts mental health and coverage. So when we think about diagnosis, not only is it important for us to communicate and categorize and label for treatment in regards for our clients, it's also a big piece on the other end, the business end, with the insurance and getting reimbursed and getting paid for. So we've got to keep that in mind in regards to dealing with while we diagnose. Some of the other cons of it, of course, is the negative aspect of labeling, a stigma. One of the things I think about when we're dealing with diagnoses is the certain diagnoses carry a certain weight. And what I mean by weight is that they have this image, this perception of what it is and how you're viewed upon, When I was coming up in my training, the big diagnosis to give everybody was ADHD. Every kid was ADHD no matter what was going on. Little Timmy can sit still, ADHD. Little Timmy likes chewing his finger, ADHD. Nowadays everybody is bipolar. You have some people who can take a diagnosis and listen to it, and it actually can bring them peace. While for there's others who get a diagnosis and can cause very large levels of distress, discomfort, shame, negativity. In my training, I know coming up, one of the diagnoses that carried a lot of negative connotation was borderline personality disorder. That was a big one. And so we had to be really careful sometimes with giving our clients that diagnosis, because some of them sometimes had really bad emotional reactivity to that label. The majority of the time they really didn't know what it was, but you had some of them who were fully aware, and it was, took it as very negative. So I started to learn the importance of the art of presentation, how to present the diagnosis, talk about the symptoms and what it presents like, and how it can be really reflective, because that's a really big key piece. I'm a firm believer when it comes to working with clients and the importance of presentation. There's an art of how we present things, and how we discuss, and how we reveal information to our clients. I can tell you that you're crazy, but depending on how I say it, how it is, will give you a different response and reaction to my words. For example, if we are in session and I give you a personality assessment inventory, and I get the results back, and I say, you know what, Mr. Jones, I've given you this test here and got the results back, and man, you are crazy as hell. Woo, man, something wrong with you. Now, if I was to say that in a session, more likely Mr. Jones will come across the desk and we're going to fight. Because he's going to be upset, he's going to be disgruntled, and almost like I'm being very judgmental. But if I would say, Mr. Jones, we got the results back from this test, and it seems like here that by the results, it looks like you're having a really hard time to kind of differentiating what's real and what's fact. You have a hard time attaching things to reality, difficulty relating with others, a lot of internal conflict and turmoil to where it really negatively impacts your day, where you have a problem interacting socially, performing at your job, having relationships. Even being by yourself sometimes can be very problematic because your mind is racing so heavily that cause you a lot of distress, a lot of impairment, and also some frustrations and aggravations to where the point where you are really, really can be difficult to deal with at times amongst your friends, and you've reported that as well too. So we may want to look at how you're viewing things and looking at how what's be the best method of approaching what's going on with your situation. So crazy as all get out versus you really having a hard time getting along with others. A lot of reality-based issues are going on for you. That art of presentation, that's the big key piece of this. With while we diagnose, putting that package together, sealing it out there, and presenting it to our individuals and our clients so they can really get a good grasp of what's going on. Okay. Kind of going back to the whole notion of the phrase normal versus normal. Versus abnormal. We are studying psychopathology, so we're looking at some of the behaviors that don't fall on that typical bell curve. We'll call what's normal. We have some of the extremes. We have people who are almost heavily excitable, the manic individuals, the people who are lethargic, don't want to move, the depressed. So we're looking at a whole spectrum of things, and it's really important that we use the DSM and those diagnoses to really get that information across. And it's so very key that when we talk about these diagnoses, these labels, that we treat the label, take it back. We treat the person who has the diagnosis. For example, it's important that we say we're working with Mr. Jones, who is suffering from bipolar disorder, instead of saying Mr. Jones is bipolar, which is something we've done for years in the profession. And it's very, 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 very hard for us to break that mold. We have to keep that in mind, that we're treating the disorder and the person. There are two separate things. The person is suffering from, like, having diabetes or high blood pressure or, any other health condition. It's the same principle in regards to that. So just think about the benefits of what we do to diagnose, because we get so much information from it amongst us professionally, clinically, and also for the grasping of the client. It can give them peace to have that label, to have that understanding of, that's it. I finally figured out what's going on with me. But also at the same time, it can cause such turmoil and distress that we have to be very careful that we educate. One of the best things we do have is also one of the worst things we have. It's the internet. I will bet my life, my career, that you will have clients to come to you in your office with printouts of what they already have before they walk into the door, at least once in your career. Oh, this is what I got, doc. I looked it up the other day on WebMD. Or, I've had a client come in, bring in the DSM before, print out a page with this is it. I'm 100% for sure. I don't even know why I'm coming to see you. I'm dealing with this. This is what I got. This is what I am. So those things happen. And on a side note, I'm pretty sure in this class, we discuss a whole host of disorders and diagnoses that you're going to see things that you may see in yourself or people that you know. It's very common to look at this disorder like, ooh wee, that's my husband, or that's my wife, or aha, I know why we didn't work out in a relationship, because this person had this disorder. It's going to happen, and that's part of the process. But it's also helpful because if they actually do fit that criteria, that could be a mental key point for you thinking about what that disorder looks like in an individual, how it presents. So it's very, very helpful. So I'm done with the video for the evening. I hope you all enjoyed it. I hope it was much better than the other one. I will see you in week 2. All right, take care.